time now. Thank you so much, everyone, for joining. Do we have Marcel, our regional rep, with us? Marcel, are you there?
Yes, please. Marcel is.
He's
Marcel
connected. Okay. Marcel, yes, Mr. Marcel Akpovo is the regional representative of the OCHR East Africa Regional Office. Yeah, he will be doing the opening for us. Welcome everyone from across Anglophone Africa to join this topical webinar on the impact of COVID-19 on mental health. English will be the medium of communication for this discussion, obviously. We'll have another one for Francophone Africa in another time. Captioning service will be provided for so for those interested. You can also, I think it's more for the other users also in the YouTube also. So without further ado, I'm giving the floor to Mr. Marcel Akpovo, regional representative, who will do the opening remarks on behalf of the organizers. Thank you, Marcel.
Thank you, Abdul, and then thank you, colleagues. Thank you, thanks to all the participants. I will just be very, very, very quick, and then allow you to have your much more important conversation on in the context of this webinar. Dear member of the UN and then African Human Rights Mechanism, a representative of intergovernmental, governmental and non-governmental organizations that are at the forefront of effort to alleviate the impact of the pandemic on the right to mental health in Africa. This is really, really to warmly welcome all of you to this very topical and timely webinar on the impact of COVID-19 on the right to mental health. A right which, as you all know, is very critical to the full realizations of the right to health, and which unfortunately has lagged far behind in its realization in Africa so far. This opportunity and through this webinar is a part of a worldwide series of organized webinar in various regions with a common objective to identify promising practices to enhance the human rights-based approach to the response and recovery efforts. In the eastern and in the southern part of the African region, like in many other regions, we have exerted a lot of effort to integrate a human rights-based approach in the health and in the socio-economic response plan developed by countries based on applicable guidances issued by the Secretary General, the United Nations High Commissioner for Human Rights, and the Human Rights Mechanism, with the view to help initiative to recover and build back better. In a very cursory manner, I have a look at the list of the panelists, and then I can indeed confirm participants from peer-to-peer webinar with a lot of interest. By the way, when I was going through it, and I realized that I personally and then also professionally know many of you. So it's really increased the interest in sharing this preliminary thoughts with you as you enter in this conversation, in this discussion, in the context of this webinar. We shall indeed look forward to the outcome of the discussions, which definitely will inform our interventions in the sector as well as the upcoming planning processes. We are hopeful, definitely, that we will be collaborating with most of you through our respective OCHR presence to enhance the enjoyment of the right to mental health in the region, including in the context of recovering better from the pandemic. May I take this opportunity to thank indeed the member of the United Nations Treaty Body, colleagues of the OCHR, Eastern and Southern African region, and then the Human Rights Treaty branch, especially the capacity building program, all of you for organizing this webinar that I believe would be very productive in terms of new ideas, in terms of how we see the future better and then build back better. I wish you a very productive and then fruitful deliberation, and then I look forward to hearing from you as you complete this conversation. So thank you very much, colleagues, and then I will hope that you have a very pleasant and a nice time together. And back to you, Abdul.
Thank you so much. Thank you so much, Marcel, for those remarks. Without further ado now, I give the floor to our moderator, Professor Philippe. He will introduce the panel and take over from here, everything. Thank you so much. Philippe, the floor is yours.
Thank you very much for those introductory remarks. Good morning or good afternoon to all of you. It is 1:30 in Switzerland, where I'm speaking from presently. Let me just say that I'm absolutely thrilled to moderate this webinar. My name is indeed Philip Jaffe. I'm a clinical and forensic psychologist by training, and from the academic branding visible on your screen, you know I'm a professor of children's rights at the University of Geneva and a member of the UN Committee on the Rights of the Child. My job during this webinar is twofold. Firstly, I will try to squeeze as much knowledge and creativity as possible from an amazing group of panelists and discussants, all human rights and mental health specialists. Secondly, and much less glamorous, is to act as an enforcer to make sure the program progresses on schedule, and for this I will apply the Swiss timing method, and when necessary, rudely interrupt speakers. And I do hope they will forgive me. The goal is to help us meet the objectives of the webinar, and let me very briefly remind us all and the audience that's outside of all the context and the objectives. In addition to the economic havoc, COVID-19 has introduced an unforeseen and monstrous global mental health crisis that has disproportionately affected vulnerable persons and populations. And to address this crisis, we should be grateful that OHCHR has taken the initiative to conduct regional webinars, this being the third after a similar in-depth discussion in Asia and one held in the MENA region. Today, we are addressing Anglophone Africa. There may be one or two exceptions, and asking our panelists and no less distinguished discussants to brief us from their perspective on how the mental health needs are being addressed or not, in particular from a human rights perspective. I do hope that by the end of this webinar, we will be able to take away what innovative and effective mental health programs have been developed to address the palpable anxiety, distress, depression, or worse, experienced by so many children, young people, persons with disabilities, women, but also men, persons from ethnic minority groups, and all those who before the pandemic were already scraping by in the lower socioeconomic rungs. We need to better understand the effects of COVID on mental health, what has and what should be done to counter its impact, and going forward, how we can proactively build on this crisis to enhance equality and resilience in our communities. This means allocating resources, conceiving effective government programs, but even more fundamentally, we must give voice to the persons who are affected. Let me end here this very brief introduction and simply add a couple of housekeeping rules. I will introduce each of the 6 panelists and ask them to share their most synthetic thoughts on the issues, but no more than 5 minutes. I will then ask for reactions from our wider group of participants. To intervene, dear participants, please write your name in capital letters in our chat box. If you can't write, please raise your hand or speak up. I will call you out by name to give you the floor. But please, we have little time, so your remarks must be very short. 2 minutes maximum. Do not give a speech. Do not describe detailed programs. We need you to bring us snippets and ideas and short questions. If you are long-winded, I will again rudely interrupt you, so all the participants have a chance of sharing a few thoughts. It is often said that a basic human right is the ability to practice turn-taking in a conversation. Let's try it out. So let me move to our first panelist, Mr. Elgun Safarov, who is a member of the Committee on the Elimination of Discrimination Against Women, CEDAW. He is from Azerbaijan, and he is a professor of law. Elgun, you have the floor for 5 minutes.
Thank you very much. Thank you very much, dear Philip. Thank you very much for the OHCR for the inviting me to participate in such kind of interesting webinar. I will try to include the main points about the work of CEDAW committee and understanding of the mental health work implementation policy in the world. So the CEDAW committee, so the CEDAW convention and decisions which was done to the communication and inquiries on the mental health approach. I want to underline that mental health, which is development of the protection of the mental health rights during the last 25, 30 years on the regional level and universal level. Universal level through the international organizations as the United Nations and the regional organizations at the same time in the implementation on the court level at the same time. Terminology, definitions, implementation policy, it's creating last 20, 25 years. It's different with the regions, we can compare it. But I want to try to underline the point of the protection of women's rights and girl rights and mental health and violations of these during the COVID-19 questions. Only each day we see that more than 48,000 girls forced to the marriage. Each day we see that more than 10,000 women are victims of the domestic violence. And all the violence questions going with the physical, it's compared during the same time with the mental health. Psychological violence against women and girls in this point, especially in the family and domestic line. But in international level, we see that the creation of the 10 treaty bodies, which developing and including in our work, which implementing this policy throughout each levels. I want to underline that all articles of the CEDAW Convention and all procedures include the same time mental health questions points in our understanding. The first article and the second article about discrimination, gender discrimination or discrimination on the ground of sex. It's the same point, including not only the physical, but at the same time mental, psychological discrimination and understanding. Implementation in the national legislation acts, adoption through the way. At the same time, we say the implementation of the 5 and the 6 articles of the CEDAW Convention, which includes in our work the main appointments, domestic violence, stereotype questions, stereotype matters on the stereotypes, including in our communities, world communities, state communities at the same time in the implementation of fighting with the stereotypes as domestic violence. And as we see the 6th article, direct implementation, so the communication and inquiries questions of the CEDAW Convention is a prevention of trafficking, especially trafficking of women, organs, girls, also say important questions which in underlined in our work. And it's very important points, the domestic violence and the trafficking articles, which are including by the states at the same time in the reporting procedures. I will do not stop article one by one. I will go into the health questions, especially mental health. We have the 11 and 12 articles of the CEDAW Convention, which implementation directly to the mental life. So directly through the protection of mental rights, especially in this point. Is especially including marriage or maternity leave questions, at the same time healthcare or in order insurers. As we see is obstetric, for example, we have the obstetric violence cases which include directly through our new communications, and each member of CEDAW committee trying to include the mental health, psychological care, and including through the recommendations to the state reports for the implementation directly. So this COVID-19, we see the going the deeper the violation questions, especially violence against women and violence against girls. And we're trying to protect, creating a special procedures, creating a special new recommendations, directives, recommendations at this point, which will protect women and girls. But it's difficult. It depends the states, state roles, and role of international standards, international legal standards, international conventions in the states. Of course, we have the good examples, but unfortunately, during COVID-19, we see the aggravation. We see the problems are going deeply, and we see much more suicides, which have direct lack with mental health and which have directly used it. But all the points we are using is in Africa, we are saying about this, we need that most population living in a village, in the rural area, and we can include that most of the violations happened in the statistic base worldwide, in the rural areas, in the village levels. That's why we sometimes need to say about the protection of human rights in the process of the urbanization, in international law, in physical urbanization, and in all lines. That's why we including family relations, child nationality questions at the same time, marriage nationality questions in this point, which are very inclusive and which are very interesting in our role, and including with the CRC and another committees, not only the CEDAW. And of course, we have the 15, 16 articles, which including directly family matters, protection of women rights at this point, and have direct lack to the another conventional norms to the protection of mental health. And of course, we can include, if we're thinking and speaking about the African courts on human rights and people rights implementation, direct implementation, right, 2 years, women rights in the mental health decisions. But it's important to give the right definitions, right, including terminology in our work in the fighting with discrimination, any grounds. Thanks a lot.
Thank you very much, Elgun, for sticking practically perfectly to your time. So let me move on to Dr. Nora Svas, who is a member of the subcommittee on the prevention of torture, and she comes to us from Norway. And if you permit a small bias, she is a clinical psychologist, as myself. Please, Nora, you have the floor for 5 minutes.
Thank you very much, and good afternoon, everybody. The pandemic has affected the world and human lives in a very dramatic way, and the consequences that this has and is going to have on people's lives and mental health, in particular their mental health, is alarming. And setting focus on this today is very important, because we're probably not there that we can expect treatment or care in relation to many of the problems that we are facing. I think that what we must have is a strategy for prevention and for early intervention in situations where there are special grounds to believe that people are disproportionately affected. In many ways, this pandemic hits and hurts what I usually call the basic building blocks of our lives, and as such, our psychological functioning. What we usually consider our main resources in our lives are being changed, limited, and reduced. First of all, life as we know it is disrupted. It's unsafe. There's less predictability in our lives. And this may create a lot of insecurity every single day. We have the additional anxiety now for being ill ourselves, or having our close ones being ill, even losing them, and not being available or not being possible to receive the health and the services that one needs when one falls ill. This is also a daily serious stress. Usually in times of crisis, support and social contact is the main recipe or the main good thing. Now we have to argue for distancing and often isolation. And of course, the losses of livelihoods are serious for many, many people in the world. Many experience they cannot do what they should do, take the responsibilities that they should have. And this, as we have heard already, lead to anxiety, to many people that are losing hope, feeling depressed, even reacting strongly in a way that may be both violence, serious frustration, conflicts in families, all these things that may disrupt our lives and our belief in the future. These situations are without any doubt problematic to all of us, but there's also at all times large groups of people that we must consider in a very vulnerable situation more than others, such as children and juveniles, persons with disabilities, LGBTIQ people, and as I will be speaking about, people deprived of their liberty. Because the SPT, the Subcommittee on Prevention of Torture, together with the National Preventive Mechanisms, which is the body that works very closely to the SPT, the subcommittee, has as a mandate to visit and to enter all places where persons are deprived of their liberty, to observe, to speak, to visit, and to monitor, and to prevent torture and ill treatment. And of course, this constitutes very special challenges as of today. So we want to stress in the SPT that persons deprived of their liberty comprise a particularly vulnerable group owing to the nature of the restrictions that are already placed upon them and their limited capacity to take precautionary measures. Within prisons and other detention settings, many of which are severely overcrowded and insanitary, there's also increasing acute problems. We can give examples. There's a lot of less activities, regular activities in the prisons, hospitals, migration centers, and other places where people are deprived of liberty, less chance to be out in the air, less chance to do the regular things, much less contact with family, which is a very problematic situations in all the places where there's no special mental health care units in the hospitals or the prisons, and where basically all the support to the individuals come from the family. This is now not longer possible. We do have an increasing amount of health problems and services that are decreasing, and a disproportionate tightening of security in many places of deprivation of liberty, including long lockups in cells, executive use of isolation measures, and suspension of communication with the outside world, which occasionally have already resulted in violence and riots. We also know that there's the suspension of existing forms to leave home, for instance, for persons deprived of liberty, and also very serious restrictions on complaint mechanism. There's deficiency in delivery of hygiene material in many places and personal protection equipment, something which has problem both for the staff and for inmates. And of course, the usual monitoring visits to places of detention is no longer possible, or at least not in the same way as it usually has been. So based on these concerns, the SPT has already issued an advice to states and to the national preventive mechanisms on relating to the coronavirus pandemic, and the SPT has, based on this again, interviewed and received a lot of information from different countries in the world about their best practices and understandings of the situation. And based on this again, we're issuing now the second statement on from the SPT, including some of these practices. And in particular, I would like to mention the importance of really having a special focus, and this is our advice to the states, to have the particular focus on the mental health consequences, and if possible, create special units for COVID-19 patients with mental health problems. We also want a strategy to try to reduce the overburden of the pandemic or the consequences, for instance, overcrowding. Extremely important to reduce overcrowding in all possible ways and reduce passivity inside the places of detention. There need to be a strengthening of alternative activities and contact possibilities. And there are many examples of prisons that have tried both mobile phones and other ways of contacting families in order to compensate for the loss of contact. We also need to strengthen all ways to provide information both to people inside the places of detention, but also to family. Lack of information is a stressor in itself. We need to strengthen, in particular, the needs of women, juveniles, and persons with disability inside the places of deprivation of liberty, and also work very hard to find possible alternatives to places of detention. And I'm getting to my last sentences now. And I think one of the important points also that we want to argue is that the staff has to be prepared to understand what are the reactions and how reactions of persons in detention can be understood as reactions in relation to mental health problems acquired through this very serious process. So being more sensitive and aware of these things is also something important for the staff, including support to staff which are under severe stress. We're also arguing very hard for the vaccination programs to be included for all persons deprived of liberty, and also the staff, including medical staff in the places. Again, finally, the NPMs to strengthen their work as much as possible to visit, find different ways of visiting. We have in our statement some alternative ways that this can be done. Again, strengthen, monitor, and information work, and try all possible efforts on state and NPM level to reduce the extra additional costs of the pandemic, in particular overcrowding and lack of healthcare. So with these words, I wish you a continued webinar and look forward to listening to the discussion. Thank you very much.
Thank you very much, Nora. And we're going to try and catch up a little bit of time. I'd like to give the floor to Mrs. Gertrude Fefuame, who's a member of the Committee on the Rights of Persons with Disabilities. She's an experienced educationist and advocate from Ghana. And please give us your perspective on the pandemic's effects. Gertrude, you have the floor for 5 minutes.
Moderator, distinguished ladies and gentlemen, all protocol observed. Thank you for this opportunity to share my viewpoint and also on the rights of people with disabilities when we're talking about the right to mental health. So I will speak more from the grassroots advocates and bring the rights. My first part will discuss the generic issues, zoom into the situation of persons with disabilities, and some suggestions for inclusive attempts. So as we said already, it's been so difficult for everybody worldwide. It has also created new barriers for people who already have mental health challenges. So more people are experiencing post-traumatic stressful disorders. There is anxiety, there is depression, and where the studies like in the US indicate about 4 out of 10 people are already reporting symptoms of anxiety. And the impact of this on mental health in Africa is more pronounced because of not having strong health care services. And we did experience this also in the Ebola. And we have taken this information from surveys and anecdotal evidence. So we know what people have experienced. Further research on the psychological impact of mass trauma, such as disasters, have also shown, and previous speakers have mentioned, that it is worse for people who are marginalized. And among these are people with disabilities, and no doubt. So in this process, access to resources, discrimination and stigma are heightened. The situation of people with disabilities in the various situations is updated. The information that were coming on hygiene and practices protocol, physical, social, you name it, are the safety measures that were put in place. But for we people with disabilities, it had adverse effects because we couldn't access our support services. We couldn't freely interact with our personal assistants, families, businesses, institutions, all get different, and it hasn't recovered yet at all. So our access to health was seriously affected, and those with mental health conditions, those with psychosocial, intellectual, had more situation that is today. The intensification of feeling of loneliness has also heightened and have caused many more people to experience mental health conditions. And yet many more of us are not able even to go to report because access is also a challenge. Elsewhere, it also came out clearly that people in institutions did get more infection, including people with disabilities, more infections and death. In Africa, we do not have so much of institutions, but it affected family, home, community breakdowns, and the anxiety and frustration has been very high. As we move on, for women with disabilities as an example, the situation deteriorated because violence, as said by UN, that there was a shadow pandemic that was taking place. And so many women with disabilities experience violence, and it hasn't been sorted out because the services already in the communities are not reaching out to many. So you can imagine what the situation is. Let's think about children as an example. Going to school was an interaction for those who could engage in school activities. But the lockdown to curtail the spread of the pandemic meant that many children lacked the access and therefore were locked at home. Moderator, when I have 2 minutes more, please let me know kindly.
Please 1 more minute, Gertrude, if that's okay.
Thank you. So what we want to express is that the recovery and response program should ensure that people with disabilities are in the center. Persons with disabilities issues, both in the training of the psychologists, the clinical, the nurses, and everybody, should be improved. And in this improvement, the person with disabilities decision-making must be vital. We can make decisions. Sometimes we need support to do it, but please allow us to make decisions and be involved in what is happening to us. The innovations that are taking place, please make them accessible, information, communication, and reduce the stigma. For instance, that people with albinism spread infection. It's not true. Finally, please engage the organizations of persons with disabilities in support of the interventions and innovations. A world or a country or a nation or a community that persons with disabilities are fully included would mean that no one will be left behind, and we will improve 5 times from where we are. States, civil society, human rights defenders, everybody, please take our message and leave no one behind, including persons with disabilities. Thank you very much.
Thank you so much, Gertrude, for bringing the voice of the community of persons with disability and for emphasizing participation at every stage. I would like to move on. I hope we will come back to your points and to your call. I'd like to move on and give the floor to Mr. Aboubekrin El Jera, who is a member of the African Committee of Experts on the Rights and Welfare of the Child. And he is from Mauritania, and I congratulate him on his recent re-election, and please give us your insights from the African Committee's perspective and on children. Thank you.
Thank you very much. Thank you very much, the panelists. Yes, I am Anglophone from the Committee of African Rights and Welfare. I think that now in Africa you have needs to have a policy and the plans relating to child and child mental health. You know that the children are our future. Policies and well-designed plans allow governments to promote mental health for the benefits of families, community, and society overall. Children and adolescents who are in good mental health can obtain and maintain optimum social and psychological well-being and behavior. They have sense of identity and self-confidence, stable family and relationship equality, the capacity to be productive and to lean to potential to meet development challenges and use cultural society format. Grow has to have, growth to have a high level as possible. In addition, the good mental health of children and adolescents is essential as part of the active participation in economic and social life. Major funding gaps are holding back and describing critical mental service in Africa. And you know, the COVID-19 as making a big crisis in to access for child to a mental health. At now, I think that the committee of child are making a studies of the situation of children in Africa, and they have so many uh, uh, rights of children will be breaking about the population. The pandemic COVID-19 uh, is uh, is making a crisis in the children rights in the continent. I think that it is very important. The United Nations brings a policies and plans to encourage the possibility for the child to have his rights. The organization, the World Organization, has making a study who has shows that the survey conducted in 28 African countries was carried out a part of the first global assessment of the devastating impact of COVID on access to mental service. It is underlies the urgent need for increased funding of the responding countries in the Africa regions is 30, 37 reported on the COVID mental response plans are partially funded and 67 they have no funding. That means there are a problem in Africa to have a solution for for the rights and welfare of the child in the continental. The committee will be making uh, an effort to have a response for the mental child to have a good psychological to go to study to making his activities and you have a problem for the child who have disabilities. It will be for interesting that the committee or the Union African organs making a mechanism to have good responses for the rights of child in Africa. You know that at now the COVID, the pandemic COVID-19 have a bad impact of the child, of his development, of his service of the children is the continental. I invited the United Nations to have a good policies and plan to rated a good response to child and to child mentals in Africa. The committee are making studies of the impact the COVID in Africa for those children has shows that we have a big problem for the child to go to school, to have nutrition, to have to play. It is a very problem to have who has the children up now in the continent. I hope that this webinar is very important to know up now what is the impact of the COVID-19 on the child. You know that the children, it is the weakest element in this chain. I think that it is very important that the United Nations rights make a good plan, a good planification for the Anglophone African countries to have a good response for this pandemic.
Abu Bakr,
You know
can I ask you to conclude, please?
What?
Could I ask you to conclude, please?
Yes. I conclude. My conclusion is that the COVID-19 has making multidimensional cases with health, socio-economical, and civil and political rights dimensions, particularly for the children. The children is our future. The children will be in a good health. The children will to have a good survive. I invite the United Rights to make a good response in this decades to have a good response for the children in Africa. Thank you very much, Philip. And I wait your questions to Queen another for this important webinar on the impact of COVID-19 on the rights and mental health. Thank you very much.
Thank you so much, and thank you for all the work you're doing in the African Committee on the behalf of children. So important, and such a big segment of the population. I'd like to move on to Ms. Bharti Patel, who is the Executive Director of the South African Federation on Mental Health. And she directs an organization that has a significant national impact. So please give us a bit of a sense of what's going on and where you're heading in terms of your engagement. Bharti?
Thank you very much, and a very, very good afternoon to all. The South African Federation for Mental Health is a national non-governmental organization in South Africa advocating for protecting and upholding the human rights of persons with psychosocial and intellectual disabilities. We are in existence for over 100 years, and we have 17 member organizations who provide community-based mental health services throughout the country. I wish to focus on the impact of COVID-19 on the services provided by these organizations and how it indirectly also affects mental health care users in the country. Our Mental Health Care Act, while it is aligned to international human rights principles, it does require a review so that we can address mental health services within emergency settings. We need to relook at terminology and also look at accountability for the provision of mental health services in the country. The already lapsed mental health policy framework and strategic action plan also requires a review. The reports by our Health Ombud and the South African Human Rights Commission had shown that the policy was poorly implemented from 2013 to 2020. And it is actually during this time that gross human rights violations occurred. The Life Esidimeni tragedy in 2016 resulted in the loss of over 144 lives of persons with mental illness, and yet no one is held accountable. So while mental health in South Africa is extremely essential given our oppressive past, we find that the current democratic government has neglected prioritization of mental health for South Africans. A recent report on mental health investment case released in 2020 shows that 86% of our mental health budget is spent on tertiary institutions. 24% of mental health patients who are discharged from inpatient care are readmitted within 3 months. And this revolving door pattern of care consumes 18.5% of the mental health budget. We also see huge variations between provinces in terms of their allocation of their budgets towards mental health. So mental health has to be approached from a human rights perspective rather than a medical model. The lockdown regulations in March 2020 enforced social isolation and limited access to health for all. We've received reports where people were mainly looking for community-based care services as families struggled to practice physical distancing with mental health care users in densely populated homes. So we noticed also there was an increase in the need for mental health information in terms of how to access services. From an economic, social, and cultural right perspective, persons with mental illness could not access skills development programs, which also provided daily nutritional meals to ensure medication adherence and support. Most community-based facilities had to use their reserve funds to purchase medication for mental health care users, as our primary healthcare clinics did not have medication available. This is an ongoing problem, but it was made worse during the pandemic. Community-based organizations also were not paid subsidies and had to rely on donations to buy food and purchase protective equipment. And social workers and care workers, who are essential services and mostly female, did not receive salaries for months, which also impacted on their own families, as some are also single parents. So while the government, in their reports to treaty bodies, acknowledge the significant role of community-based organizations in providing psychosocial services to communities, there is no financing model for community-based organizations that will ensure a holistic service to persons with mental illness. The disrespect for community-based organizations is painful, as government appears to discriminate against women employed by non-governmental organizations, as well as those persons with mental illness who are in receipt of services from community-based organizations. Despite this discrimination, we find that our organizations are quite resilient, being able to provide food parcels to mental health care users and their families, and also included COVID-19 information about how to protect themselves from the virus. Ongoing psychosocial support via WhatsApp is proving to be extremely successful to prevent relapse, and also ensuring that the public health system is not inundated or overburdened. In terms of the right to mental health, we do need to review our policy and make sure that there's adequate resourcing for immediate implementation. The intersectoral collaboration between government departments is absolutely essential, because to date, we haven't even heard from our Department of Social Development in terms of how it plans to address mental health in impoverished communities. So we need to see mental health not as a sole responsibility from the Department of Health. We need to recognize community-based organizations as equal partners in service delivery. So the total package of care is critical to ensure that the mental health care user, their civil, political, economic, cultural, and social rights are respected, protected, and fulfilled. Thank you so much for this opportunity.
Thank you very much for that substantive contribution. And I'm sure we can come back to some of the moving parts you flagged. I'd like to give the floor to Dr. Bengana Kamayonsa, Florence as well, who is a WHO Regional Advisor on mental health and substance abuse. I see you put on your camera. The floor is yours for 5 minutes, Florence.
Thank you. Thank you very much. I will try to do it within the 5 minutes. I will start off by talking about the vulnerable populations. It is a very long list, and we have had even more talked about today. And we can also talk about the interactions between the categories. A woman could be an ethnic minority, as an example, and also be displaced or be a refugee. We also have one, I think, very painful example of somebody, an individual, an LGBTQI individual in Kenya, who was unfortunately murdered, a refugee who was unfortunately murdered for what he was. We also have the issues of stigma and discrimination. So if you have most of the people who are vulnerable populations are often stigmatized and discriminated against. And we know that people with mental disorders are also stigmatized and discriminated against. And that whole interaction both ways makes it very difficult, first of all, to seek care. But when they do seek care, sometimes even the care services discriminate against them. The other issue I want to talk about is that of mental health conditions. They are not one thing. We tend to think if I have malaria, it is malaria. If I have TB, it is TB, it is one thing. But with mental health conditions, we have a whole variety of conditions. They range from severe mental disorders to the more common mental disorders, and then to the psychosocial disorders that are common, like in COVID or following other complex emergencies. But within our scope of work, we also include epilepsy. We also include alcohol and substance use disorders. And so we have to keep all that in mind. And it's really good that COVID has raised the issues of mental health, but it tends to raise the issue of more of psychosocial disorders rather than more the mental health, the severe and the common mental disorders. So the interventions provided tend to be, let's provide listening and helping, let's provide phone counseling, and those may not reach the people who may need the most care. They will help, of course. There has been a lot of talk about the pre-COVID mental health services. In Africa, the average from the Atlas, the WHO Atlas, was about 10 US cents allocated per person per year to mental health services. As we heard from South Africa, about 90% of these funds go to large hospitals. And this amount, that is 10 cents, if 90% goes to large hospitals, it is still not adequate. And so the quality of care is very, very poor in these large institutions. And yet we know that the majority of the population, 60 to 70%, are in the rural areas. So we have this challenge where we started off with already low financing of mental health services contributing to poor quality, leading to ultimately contributing to the abuse or not fulfilling the rights to mental health. According to the international human rights laws and treaties, standards to be met are already explained in detail in relation to respecting, protecting, and fulfilling the right to health, and therefore to mental health. It is already written in there, but currently we see that states are failing their obligations, especially in relation to allocating resources to ensure that quality services are provided. So what can be done? One, I think has been talked about, is to increase investment in strengthening mental health services. And I have to stress mental health services and not just providing the psychosocial services. The other one is Mental health plans should ensure that they address vulnerable populations and develop strategies and programs to ensure that vulnerable populations are reached. And mental health and psychosocial strategic plans must be multi-sectoral. And my last point comes to the promising initiatives from the African region or global. One, I think the most important would be WHO's executive board decision that came out in February of 2021. For the first time, mental health was discussed within the discussions on conflicts and complex emergencies. And we have a resolution that calls for the strengthening of prevention and provision of services. We also have an interagency standing committee, including many different agencies, and it has been in place and providing support at the global level. The Dutch have also been providing that such support. If anybody needs support, they can request it and get somebody to come to their countries and support the mental health and psychosocial interventions. We have regions like the Eastern Southern Africa MHPSS hub that has been holding meetings and coordinating activities and providing support to countries. UNICEF and WHO have also signed a memorandum of understanding, and we shall launch this at the end of May. But it too looks to strengthen mental health services, not just for children, but for adults as well. There are some other examples I would give, but in the interest of time, I think I will just stop there for now. Thank you very much.
Thank you so much, Florence, for being so self-disciplined. It's much appreciated for the totality of this webinar. And you made some very, very important points on supranational collaboration between agencies. I would like to move on to the other participants and invite the ones I call to give their perspective in very short interventions, their reactions, or give some good examples of practices. So I have a list in the chat. If we have time, we can take additional interventions. But the first one that is signed up is Mr. Sifiso Maxibe. Please, would you please take the floor? Sorry.
Thank you very much. Good afternoon, everyone, good day. Thank you for allowing me to speak today. My name is Sifiso Maxibe. I'm the project leader for mental health support at the SA Federation for Mental Health. One of my responsibilities is to provide assistance to the public with mental health information. We deal with a wide range of inquiries from people. One such issue is related to how people can access the public health system in order to receive their medication for their mental health conditions. The challenge that with people not being able to obtain medications due to COVID-19 related issues, where people have been unemployed and do not have access to medical aid. For them, this may be strange, debilitating, confusing. And so the SA Federation for Mental Health was able to assist these individuals by providing the process or steps to follow in terms of getting assistance in the public health system in order for them to receive their medication. So there's a few steps that we do that include getting a referral letter from their treating doctor stating what medication they need, visiting their local clinic to open a file so they can be seen by their treating doctor at the clinic. Once they are seen by the treating doctor at the clinic, they can then receive their medication. And if medication is not available at the clinic, they are then referred to their local hospital. So this type of inquiry is significant because when people try to get medication from their local clinic, medication is sometimes not available. Accessing medication in the public health system has been a challenge before and during COVID-19. The SA Federation for Mental Health would then report the shortages of medication to the Stop Stockouts campaign, and then the campaign would try to assist in finding medication for these individuals. As a mental health care user who has been diagnosed with bipolar mood disorder since 2007, I've had to experience many challenges when having to gain access to the public health system to acquire my medication for my mental health condition. There have been a few instances where my medication was not available or I was given generic versions of the medication that I'm supposed to get. And sometimes these medications did not agree with me, or it took a while for me to adjust to the new medication. Fortunately, by working for the SA Federation for Mental Health, I know how the public health system works and know where to report such issues if I cannot get the medication that I need. Getting my medication from my local hospital is no longer an issue, and I try to share my experience, strength, and hope with the people that I meet that experience the same problem. The COVID-19 pandemic and lockdown regulations have been very challenging for me, has had a huge effect on my mental health, well-being, and professional life as well. I've had to seek professional therapeutic help in order to seek solutions, coping skills to deal with everyday problems. I've had, I've been fortunate enough to receive free therapeutic counseling for many challenges that I experience on a daily basis. I've had to make constant changes in how I do my work when I'm working from home in order to find the right type of space to work from. Working from home is not easy, as family members, friends think that I'm at family members and friends think that I'm at home. Therefore, I cannot do favors for them because they think that no one will know if I'm working from home or not. So I have had to put boundaries in place in terms of my availability when I'm working from home. This has helped me a
Sifiso,
lot.
you
Yes,
must conclude, please, if you don't mind.
will do. Thank you. Um, So I'm very fortunate enough to be working for the SA Federation for Mental Health because not only do I receive support from the organization regarding my mental health and reasonable accommodation, I'm able to provide mental health support to people who are experiencing the same issues and challenges that I've experienced during COVID-19 lockdown. I'm happy to provide this service as it is a great feeling to be able to help people and to know that I've made a difference in someone's life. Thank you for giving me the chance to share.
Well, thank you very much for this testimonial and many of your inputs, in particular, the peer-to-peer help that you can provide and mentoring for other persons in need. Let me call to the floor Ms. Robina Alambuya, who speaks to us from Uganda, if I'm not mistaken, and is a voice for the community of persons with disabilities. Please.
Thank you so much. I really appreciate the UN, the WHO, the organizers, and all the participants. I'm Robina Lambuya, as you heard, from Uganda. I do serve on the Africa Disability Forum as a member of the Executive Council. I'm also a founding director for Triumph Uganda Mental Health Support and Recovery Program locally here, which is a community-based organization. I want to appreciate that the opportunity for my voice to be part of the many voices concerning mental health and COVID-19 pandemic. I was asked to just share a brief testimony. I hope I do it in the 2 minutes. The pandemic, first of all, brought a global panic, which was like, you get it from the other, you get a voice from someone and you feel panic, you also get the panic. And when you are talking to other people, like it was catching everywhere. So there was a trauma which was being passed on through TVs, through the radio announcements. And this one, personally, I was first affected as a person. Then, with the challenge of building resilience during this very difficult time, I somehow ended up with some kind of mental health crisis. I was able to connect to ask for support, my family members, and also connected with a mental health worker who prescribed some medicine because I was sleepless and tearing all the time. I was at the same time, after being affected as an individual, then as a mother and a leader, I had so many concerns about my family, the children, how safe they are going to be, how is this going to be, because some of them were not with me even as the lockdown happened. And then as a leader in the mental health movement in my country and on the African continent or worldwide, and also the disability movement, there were so many calls, people asking, especially my peers, our peers from the rural areas who didn't have TVs and radios, asking questions about this new disease. Some getting concerned, they were thinking, maybe it's a disease in the town. Are you safe? So I was getting so many calls. I was getting so many mails as a leader. You know, so many mails asking for maybe consultation, what can be done, how is this? Then so many webinars came on. And you know, you had to be glued on the computer and the situation was worsening. What did I do? What I did is that I also went to the local radio, made announcements concerning what I had heard. There was a lot of domestic violence. There was sexual reproductive health rights violations. So I raised my voice on the radio and I also raised my voice in the world news. Many of you heard me. I want to end by saying that I think what we need now to prepare for pandemics and emergencies like that, and especially COVID, which is still on, is to make sure that the mental health needs of the community members are put on the front, and also to make sure that there is support and reasonable accommodation to people with psychosocial disability who use the mental health services.
Thank you very much. Rubina, can I ask you to conclude in one sentence?
Okay, you want me to conclude? I
Please,
thought,
so we
okay.
have time for...
Okay, I have concluded by saying that I would like the everyone who is giving a service or putting programs and plans during this time of the pandemic and other pandemics that will come, or crisis, emergencies, it's important to be sensitive to the mental health needs of the people with the mental disability or psychosocial disability, also include them together with people with disabilities as we had. And also the issue of reasonable accommodation in everything, being patient with them. Thank you so much.
Thank you very much. And thank you for highlighting that every person is not only affected as an individual, but as a member of a family and as a member of society with responsibilities and different types of occupations. I'd like to give the floor to Bonface Betty. If you would please kindly, you are a program manager at the Green String Network. Please take the floor. And 2 minutes, please. Bonface, are you available? I don't see you or hear you, so we will move on to the next, and perhaps we can come back to you afterwards. Ms. Elizabeth Kamundia, would you please introduce yourself very, very briefly and take the floor very quickly as well. Thank you.
Thank you. I am Elizabeth Kamundia. I work at the Kenya National Commission on Human Rights, leading the Commission's work on disability. I wanted to highlight the role of national human rights institutions in advancing mental health during COVID-19, sharing from the Kenyan perspective. And I'll address 3 mandates of national human rights institutions as recognized under the Paris Principles. That's the monitoring mandate, the mandate of issuing advisories to state agencies and engaging in law reform, in this case, law reform related to mental health. On monitoring, the Kenya National Commission on Human Rights in November to December last year monitored health facilities, including mental health units, to understand the impact of COVID-19 on the services being offered. The monitoring exercise revealed that some mental health services had enhanced outpatient mental health care, but unfortunately, in other facilities, people who needed mental health care were unable to access services, and no alternatives had been put in place in some of these counties. And our report on this is forthcoming. Secondly, the mandate of national human rights institutions to issue advisories. In April last year, the Commission, together with organizations of and for persons with psychosocial disabilities, issued an advisory to the Senate Ad Hoc Committee on COVID-19. The outcome of this memorandum that was focused on mental health was that the Ministry of Health was more rigorously questioned by the Senate on the basis of the concerns that we had raised. And an example is a question that was raised on what has been done to deploy community-based mental health and psychosocial support services. And it turned out that positively, the government of Kenya has for the first time recognized psychologists as a professional cadre, and 134 psychologists have been absorbed in the public service and distributed among the counties. And the third role of NHRIs I'd like to highlight as I conclude is that national human rights institutions must continue to work on law reform related to mental health laws, many of which are not aligned to the UN Convention on the Rights of Persons with Disabilities. Many of these laws are not meeting our needs, and the COVID-19 has only served to put a spotlight on a mental health system that's already on its knees. So NHRIs must continue to advance law reform on mental health together with other allies, including organizations of persons with disabilities. Thank you very much.
Thank you very much for being so synthetic and music to my ears that psychologists have been validated. But just a small comment, I think it's all hands on deck when there's a crisis like this, and we could move into other professional categories to call on their help as well. I'd like to ask Chanel Nayang Nikolic to take the floor. If I'm not mistaken, you're a psychologist in Botswana. Would you please give your impressions in a couple of minutes?
Hello, hi. My name is Chanel Nayang. I'm a mental health advocate and expert psychology major in Botswana. And I would like to address that I do work for Drug Free is the New Cool campaign, as well as I volunteer for the Botswana Network of Mental Health. I would be addressing about the stigma and the misconceptions that I've had here in Botswana. And it's because, unfortunately, not everyone understands mental health problems. So some people may have misconceptions about what certain diagnosis means. And people don't really have access to these online services, which are the people that you find in the rural areas, as well as people that are disabled. Now, this has trickled down to a lot of gender-based violence situations that we have had to deal with. And another situation is that, yes, psychologists have been recognized due to the COVID, as well as relief plans, but they haven't really addressed the mental health task force, which I feel like should be brought to the forefront. And for that to happen, the government should realize that financial aid should be given to such psychosocial support groups and so forth. So with that having said, we have a lot of trickle down. If people have mental health problems, they find that they don't have access to such platforms, as well as the offices that are around. So we have a lot of gender-based violence, substance abuse that has been on the rise. So we would like to raise awareness and the stigma, because most people still have that way of thinking that it is something that is witchcraft or so on. So raising awareness by showing people reliable information, getting involved in the campaigns, as well as checking these psychologists and their credentials, because there's been a lot of pop-up mental health people trying to take advantage of these moments. So this is what we're really targeting to fight for, to raise awareness on the understanding of mental health in Botswana.
Thank you
So
very,
thank you
very
in
much.
conclusion.
Thank you very much, Chanel, and thank you for bringing us this information. I'd like to ask Charlene Sunkel to intervene. She's in South Africa and is the CEO of a global mental health peer network. Please, Charlene.
Thank you very much for this opportunity. I just want to dive right into kind of recommendations, and I think we already know a lot of these things that we need to do, and I think it's just good to emphasize it again. I think we all agree that we need greater investment in mental health to improve access, and that includes digital services as well, and of course the quality of services. And what's important is to take on a multidimensional and person-centered approach and make sure that services are built within a human rights framework. And by doing that, we need to consider country context, social determinants of mental health, and also to provide a service package that's designed for the individual and based on the needs and challenges of the person as they define it themselves, on what they basically need to thrive. I think another important aspect is the evidence that is very clear about the multiple benefits of peer support work. Unfortunately, in Africa, we see that it's still not fully recognized, and it's actually a very valuable resource. And I think it must definitely be given serious attention to integrate peer support work in the mental health system. It not only makes economic sense, but it also aligns with the recovery model and also the human rights-based practices. And I believe in instances like COVID today, I think this would have been particularly valuable to have peer support work within the mental health system to respond to the mental health issues around COVID. We also need to really look at eliminating human rights violations that are still ingrained into many practices. And lastly, I just want to say that to actually achieve all of the above, people with psychosocial disabilities must be key partners. We must be meaningfully, and I must emphasize authentically, be involved right from conceptualization, implementation, and to monitoring and evaluation of policies and services. And that includes response and guidelines to crises like COVID. Thank you very much.
Well, thank you very much, Charlene, and for delving, as you said, right into recommendations, and especially for highlighting once again the issue of participation and authentic participation. I think we need to, first of all, the list is closed because we can speak until for the next few hours. So at this point, there are only a few who will be intervening. And I've been asked if we can go a little bit over the allotted time, which to me is a bit of an admission that my Swiss timing has not been perfect. So let me give the floor right now to Teresai Barrett for a couple of minutes, and if you could be very synthetic as well, everyone will appreciate it.
Thank you very much for this opportunity. My name is Teresai Barrett. I'm in Harare, Zimbabwe. I'm a clinical psychologist and based at the University of Zimbabwe. So I just want to give a few contributions towards what we have done in Zimbabwe during the COVID-19 pandemic. Okay, so first of all, Zimbabwe, like many countries, was also affected by COVID-19 immensely. But during the first wave, we had low cases and the death rates were not that high. So we had time to sort of learn from other countries and to see what was happening. And as far as mental health is concerned, we came up with a task force, a mental health task force that was composed of different mental health practitioners, psychologists, social workers, psychiatrists, psychiatric nurses, and others. And we started off by just coming up with interventions that could be shared on social media. So we came up with social media platforms, and we started doing home videos that reached to quite a number of people at home during the lockdown. So the first wave, like I said, was not as bad as other countries. So the kind of intervention that we needed was just to address fear around losing livelihoods, fear of catching the disease, and fear of dying. And then after that, we had time to train different mental health practitioners in psychological first aid. And we got support from UNFPA to purchase equipment for a call center, which we hope that would be available to the rest of the nation. So this call center is supposed to provide the psychological first aid as we trained the healthcare workers. So that's in the pipeline, and it's ready to be used anytime soon. So just to say, I think we were lucky as Zimbabwe in that when the pandemic started, we had a sort of time to really learn about what was happening in other countries and to come up with interventions. So just to add on, we already had community interventions going on through the Friendship Bench, and they've been able to provide online services as well for people who need mental health services. So right now, we're working with CBM Global Disability Inclusion to give capacity building to people with lived experiences of mental health. And this is going on since December. And we are hoping that, by the end of this month, we would have reached quite a number of people with lived experiences of mental illnesses to learn about their human rights and to learn about their rights as well. So this is what we've been doing in Zimbabwe, and I hope that we can continue to learn from each other. Thank you very much for the opportunity.
Thank you so much, and thank you for emphasizing the issue, a word you did not use, the value of communication and technology and call centers and videos and so on and so forth, and managing through communication. I'm going to give the floor to Derek Kiza, who's also in Uganda, if I'm not mistaken. And we will be very brief because time is slipping away. Please, Derek.
Yeah, thank you very much. Like you said, I am Derek Chiza, and I work as the Executive Director at Mental Health Uganda. I think like in many other countries, there was closure of mental health facilities. Here, out of the 14 regional referral hospitals, mental health clinics in 11 of them were turned into treatment centers for COVID-19. So access to care was extremely difficult. So access to care was extremely difficult. We had a press conference, but also wrote to the ministry in the process. And later on from that advocacy, the ministry committed that they will get back the mental health clinics to us by the end of July. But by and large, I think even with a serious adverse impact of COVID-19 on many lives worldwide, we have received instead opportunities from COVID, because in the last 1 year, we now have focal persons for mental health in districts of Uganda, at least 35 of them. Ministry of Health is also already engaging all stakeholders, including civil society, in the development of an investment case for mental health, but also review of the strategic plan. for the Ministry of Health. We had a Mental Health Act 2019. Minister of Health had not done her constitutional mandate to activate the start date of the act. She has now committed that she will do this by the 18th of May. But there's also increased discussions on mental health in public space and civil society. Just recently, Rotary International was conducting an online global discussion fostering on mental health and the legal profession. But also free space, more free space in the media, both print and broadcast, which is it's very, very, very important. So I think we have opportunities that we have got from COVID. It's just important to see how to push them further. I certainly think, as I conclude, that we have paid a heavy cost for absence of community mental health care. A very big and huge pillar, especially if we are to enjoy Article 19 of the UNCRPD, the one on independent living, because then you have, it provides opportunity for decision making, but also involvement of the family in the care. I think where we still have a challenge is how we can get human rights thinking or perspective across the medical profession, because we seem to be in many times in rooms with the people who treat, and so you are one person, and then the invitation is extended to many medical people, and they seem not to understand human rights perspective.
Eric,
yes.
could you conclude in one sentence, please?
Yeah, so I certainly think that we need to do a little more around having creating an environment of provision of care, but within a human rights perspective.
Thank you so much.
Thank you.
Yes, indeed. Let's all echo that call for a human rights culture in all our professions, and how we could provide care and support, and also for highlighting the governmental reactions that were stimulated. It would be nice to be better prepared next time and not wait for delayed reactions. I'd like to ask Angelica Mkorongo to take the floor for a couple of minutes. Please, just a couple of minutes, and then we move on to our last couple of speakers. We really need to move along.
Hey, hello everyone. I'm the founder of Zimbabwe OCD Trusts, which raises awareness and support for people with obsessive compulsive disorder. And I'm also a global mental health executive member. I think most of what I wanted to say was already said by Charlene and by my colleague Tarisai, but here I just want to stress the fact that it is very, very important to include us people with psychosocial disabilities, because what I've noticed is when we are discussing or when we are doing anything, or all these peer support meetings and so on, our leaders, that is the psychologists, the psychiatrists, the people in the ministry and so on, are still finding it very hard to accept that people with psychosocial disabilities can actually come up with meaningful change. And so we really need to keep uplifting people with psychosocial disabilities. And I feel that not enough is being done to raise awareness of mental health, especially to rural areas where the videos, the friendship bench and so on cannot or are not, they are not getting there. So we need to find other ways of reaching all these people. And we also need to, have more organizations, or rather
more people with psychosocial disabilities coming on and being on board, so that at least the whole, mental health issues can be understood by everyone. Thank you so much.
Thank you very much for that contribution. Two more speakers, Barkin Dva, please, if you would take the floor very briefly and give us the summary of your thoughts.
Okay, thank you so much, Philip. I'm Barkin Dva, and I'm from Liberia. I'm a mental health clinician working at the WHO country office. With just 2 minutes, I would like to stress 3 points, key points, and that is based on my own experience from the outbreak in Liberia here. Like the Ebola and even personally the COVID, mental health and psychosocial support is usually not prioritized in the preparation stages, of the interventions. And when the evidence of need is being recognized and part of the interventions are included, it is usually not funded or very much underfunded. As most of our other speakers have said, in Liberia, we also experienced the closure of routine health services that affected people with mental health a lot. There were a lot of relapses, and people were actually searching for answers. And then even the workers, frontline workers that were treating or trying to provide some mental health services for people affected and infected were even discriminated. So, going forward, I just want to make this one recommendation, maybe that have already been stressed by Charlene. Okay. Policy makers, advocacy groups, and mental health service providers, we should really fund our voices to advocate for the inclusion of mental health services in the preparation, stages of emergencies, really. Even including the response and recovery stages, building back better. I think with the COVID, vaccines and things being available now, we are hopefully going to go into recovery, and that should be a window of opportunity to actually include mental health at every stage of the preparation and response of all of the interventions. Thank you.
Thank you very much, Barkon. And last but not least, because she lost her turn because of internet connectivity issues, Bofas, Betty, please, if you would very briefly close the discussions here, and I will conclude afterwards.
Yeah, thank you, Philip, for giving me the opportunity at least to make my quick contributions. One of the things, so I work for an organization that I posted earlier, but I would like to say my big thought now is, how do rights-based approaches integrate with trauma-informed practices to create frameworks that are culturally relevant, contextual, that work with everyday people in their quest to rehumanize themselves and break internalized cycles of oppression. I think that is where we come from in our organization, and we have created an integrated program that is not just about psychosocial or mental health, but it's like trauma-informed, holistic approach that actually is rooted in how everyday people imagine how to transform structural violence. Poverty is a form of mental health for me. It's a social justice issue. For me, mental health is a social justice issue, and it's not just a biomedical approach, nor is it just a psychosocial band-aid approach. So as an organization, we have created programs, for example, between police and citizens in the time of COVID, through a trauma-informed approach, looking at the needs of police officers and the needs of everyday citizens, and seeking to break the divide between these two groups exacerbated by COVID-19 as a social reality. And also, we have created community programs where everyday people resist, for example, police brutality and violence through trauma-informed approaches and through reimagining their realities. And also breaking cycles of violence that are rooted into intergenerational trauma for societies like ours that are post-colonial, that are impacted by the globalism and neocolonialism. What kind of structures and resiliences, points of resiliences can we build on in places where there is limited resources and broken down systems? Thank you very much.
Well, thank you so much. And I'm glad I included you at the tail end of the interventions because you brought up some important points. I'm really very sorry to have to bring up the issue of closing this extremely rich exchange that we've had. And I'd like to congratulate all the panelists and participants for their very timely and rich and engaging recommendations and observations. And you know, I have in my mind a few closing remarks that could last half an hour, but I'm not going to be greedy. I would just like to bring up a couple of points. The first is that we heard from several of you how much the echoes of the effect on a personal level can be very challenging, and how important it is to hear your voices and to hear how you have been coping and how you've been able to bring your experience of managing your distress and the effects of COVID on your personal lives to help others. We've also heard the importance of families. We've heard the importance of technology. We've heard the importance of institutions. We've heard the importance of all the institutions which are closed off, deprivation of liberty, alternative care. And we also heard about vulnerable populations who have less access to services than even the few services that exist for quote unquote the general population. And you know, I've heard about governmental programs, action plans. I also heard from one of you the role of an ombuds, and I think that's a significant importance. But what I'd like to end with very briefly is that you've all noticed, and if you could close your microphones, whoever has it on. If there's a microphone on, please close it. Yes. Okay, well, I'll try and speak over the person who has it open. Basically, you just have to realize there's a huge chain of goodwill that goes from individuals through organizations, civil society, into governmental action plans, up into specialized agencies. And so I'll end with this. I think that we should all thank OHCHR for helping us organize these incredibly important fora to exchange our views and bring experiences to the greater number of us. And so special thanks to OHCHR. Thank you to the support team, and a shout out to all the participants who were observing, excuse me, and listening out there on YouTube. It will, this series is the third, this is the third installment of the series. There are a couple more, at least that I know of, for Francophone Africa and for Anglophone Europe, and maybe a couple more, I'm not so sure. So I hope you will participate if your language capabilities allow you to. Thank you so much, and I'll close with this, and I hand it back to the organizers. Abdou, if you would like to say a final word, perhaps to everyone. Thank you.
Hello, Philip.
Please go ahead.
Yes, it looks like Abdul is busy with other things.
Oh,
I just,
okay.
Yeah, I just want to step in.
Please.
I want to thank you for the excellent moderation. I also want to thank the panelists and also the participants as well. And thank you for all your inputs. And thank you for availing yourself to be part of this webinar, and we look forward to engaging with you further. Thank you so much.